Good afternoon. I'm Philip Bendick, the Technical Director and Director of Surgical Research in the Peripheral Vascular Diagnostic Center at William Beaumont Hospital in Royal Oak, Michigan. And this afternoon, I'll be talking to you about the mesenteric Doppler examination. Good afternoon. I'm going to talk to you this afternoon about mesenteric ischemia and some of the Doppler techniques we have using duplex ultrasound to evaluate that particular disease process. Again, one thing I want to point out at the very beginning, since we'll be talking about duplex ultrasound, is I like to differentiate between so-called textbook images, such as the one you see here with a clearly seen celiac trunk, hepatic and splenic artery coming off the proximal abdominal aorta, which you would like to publish in an article or a textbook, and real-world images, which is what we see clinically. Hopefully you will see predominantly real-world clinical images today and not so much textbook, so you don't get discouraged when you try and do this examination. The mesenteric vascular study can be either arterial or venous depending on the patient's presenting symptoms. On the arterial side, we're primarily interested in three vessels: the celiac, superior mesenteric, and inferior mesenteric arteries. On the venous side, we have the superior mesenteric vein, the splenic vein, the entire portal hepatic system, and the inferior vena cava, and we'll address all of these throughout the course of this talk. But I first want to mention and differentiate acute from chronic mesenteric ischemia, and in regards to acute mesenteric ischemia, point out mortality data. That if you look at the literature over the past 35 to 40 years, the mortality is about 70% from this particular problem, a very high mortality rate. It is not that we didn't know how to deal with the problem 35 years ago and do today, because if you look at articles over the past 10 years, the mortality rate still remains approximately 70%. And it is not a matter of experience. If you look at the large series published in the literature, not just the very small series of people who do not see this disease that much, the problem is 70% mortality. Now, more recently, in an article published from the Mayo Clinic in 2009, looking at a large series, they had reduced their mortality to just under 50% from that previous 70%, very simply by making the diagnosis early and using aggressive treatment and management. And that is really the whole point of talking about acute mesenteric ischemia. Early diagnosis and treatment prevent mortality in many cases, and therefore, when you suspect acute mesenteric ischemia, it is indication for exploratory laparotomy and possible repair. This is not an ultrasound study. We do not get a duplex ultrasound study to rule out acute mesenteric ischemia. It wastes precious time in establishing the diagnosis and increases to the delay in diagnosis and ultimate patient mortality. Now, the main heart of this lecture on the arterial side is chronic mesenteric ischemia, primarily due to atherosclerotic disease, an example of which is shown here. When we're talking about chronic mesenteric ischemia, it presents typically with a very classic clinical picture. It occurs about 3 times more frequently in women than men. It is associated with frequent nausea. It is often and very often associated with postprandial pain. It is associated with diarrhea, and a patient may suffer over a period of time significant weight loss. All of this which can lead to a complete fear of food syndrome. The patient recognizes very quickly, if I have something to eat, I'm going to be nauseous, I'm going to have a lot of gastric pain, I will ultimately have diarrhea. So they stop eating because of this, and that leads to the weight loss. If you look at the age group for chronic mesenteric ischemia, it's a classic atherosclerotic population. Average age typically is 65 years with a wide range. If you look at symptomatic presentation, it's the classic syndrome that was just described, with virtually all of these patients complaining of postprandial pain. 3/4 of these patients have had a 20 to 30 pound weight loss over the preceding 3 to 4 months, and about half of them have developed an outright so-called fear of food. Typically, the vessels involved are the celiac trunk and the superior mesenteric artery. The lesions, because they're atherosclerotic, tend to be at the origin of the vessel, and it is not surprising that aortic disease is not often seen. The proximal abdominal aorta, where these vessels are located, tends not to be involved with atherosclerotic disease very frequently, and the absence of aortic disease should not sway your thinking in an ultrasound examination one way or the other. It's the typical finding. If you look at the clinical series out there, on average, there are 2.5 of the arterial systems involved. It is very, very rare to have chronic mesenteric ischemia that's symptomatic with only single vessel involvement. And that would typically be a complete occlusion of the superior mesenteric artery. But that is an extremely rare phenomenon. Roughly half of the patients will have 2-vessel atherosclerotic disease, typically celiac, trunk, and superior mesenteric artery. And just under half of the patients with symptomatic chronic mesenteric ischemia will have all 3 of the major arteries involved by atherosclerotic disease to one degree or another. If you look at this angiographically, what you see or tend to see are stenoses involving both the origin of the celiac trunk and the superior mesenteric artery, be it conventional angiography, CT angiography, magnetic resonance angiography, whatever technique you propose to use. You will see at least 2 vessels involved. You may see a dilated inferior mesenteric artery and the evidence of collateral flow if the chronic mesenteric ischemia has been persistent for a long time. Interestingly enough, there's significant delay in diagnosis in this process as well, though this is not so much life-threatening as acute mesenteric ischemia, in that it takes 12 to 18 months from onset of symptoms on average in the reported series to reach the definitive diagnosis. Typically, the problem in diagnosis arises because when the patient presents to their referring physician, they go through the litany of complaints and symptoms that they have, and they mimic, in many cases, the same kinds of signs and symptoms one associates with many of the gastric or gastrointestinal cancers. So the patients get an immediate workup with CT and X-ray evaluation for cancers, which are never found, and ultimately the diagnosis then leads to chronic mesenteric ischemia. I would hope through this talk to encourage the awareness of the hemodynamic factors involved with this and urge an early duplex ultrasound examination in patients with this symptom complex, because it's a very easy half-hour examination to sort out chronic mesenteric ischemia from normals using duplex ultrasound. In terms of the technique, in preparing the patient, it's relatively straightforward. These are outpatient studies. There is no urgency about this. It is a chronic process. It has been going on for months, if not years. So they are scheduled first thing in the morning, because the day before the examination, we call and remind the patient that they should have a light meal the night before. They should try not to eat any heavy foods or greasy or fatty foods. After midnight, they should be NPO. And on their way in for the examination in the morning, they should definitely not engage in any smoking, gum chewing, candy eating, anything of that nature, as all of these will contribute to significant bowel gas, rendering the study much more difficult to perform. So this is all the patient preparation we really need to do. We do tell patients the day before, when we call them, if they do need to take medications for any other medical problems, it is perfectly all right to take those medications using small sips of water at their normal time. But again, a light dinner, NPO after midnight, and refrain from anything on the way in for their appointment. From the sonographer's perspective in terms of technique, this can be a difficult examination, particularly if there is extensive bowel gas. So don't struggle and frustrate yourself. Then again, if you see one approach is not working, this is a study in which you can roll the patient around, get the patient involved, and do a number of things. So don't hesitate to move that patient around to see if that bowel gas will move out of the way. And you can use other acoustic windows, as it were, in the abdomen to achieve the data you need. You also need to learn to optimize your controls in terms of gain, pulse repetition frequency, scale, sample volume size, etc. All of your controls optimized for an abdominal vascular study. This means you are looking for a small target, the mesenteric arterial system in this case, at the bottom of what we would consider a deep pit at the bottom in the retroperitoneal space of the abdomen. So it can be a technically challenging examination. For example, if you're setting up your color Doppler imaging, You want your scale relatively high. You're looking for arterial flow, you're looking for stenotic flow, and you want to differentiate arterial from venous flow. And in fact, by setting your scale or your PRF for your color Doppler imaging relatively high, you will eliminate a lot of the venous interference that you might otherwise get in that abdominal examination and highlight just the high velocity arterial flows. You will also be prone to less color flash and less aliasing in your color Doppler system. You can increase your wall filter as well if you like, and if you need a higher frame rate, simply narrow your color Doppler region of interest to the area in which you are primarily concerned. You do not need color Doppler throughout the entire region of grayscale interest. Also, don't forget your zoom feature. It's much easier to see a relatively large target than a small target. So once you've identified where the vessels are and you know where you're going to interrogate these vessels, feel free to zoom up on that site and use that to help you. In terms of spectral Doppler, again, you want as large a spectral Doppler signal as you can get, so set your scale so that your spectral Doppler display basically fills the space available. Use a large sample volume size. There's no reason to have a tiny, small sample volume. There will be vessel motion, and if the sample volume is large enough, even a little bit of vessel motion, it will stay within the sample volume and you get a continuous signal. If you have a very small sample volume and your vessel moves in and out of the sample volume, you'll get an interrupted signal and it will take you much longer to complete the examination. You want your wall filter settings for spectral Doppler set relatively low so you can see all of the diastolic flow that may or may not be present. And as a final tip, you want to use the highest Doppler frequency possible because this will give you the strongest Doppler signal. This is always a trade-off between Doppler signal strength and attenuation, so start with the highest Doppler frequency the probe will allow. You can work your way down to lower frequencies if there is too much attenuation because of tissue path length involved to get a good spectral Doppler display. And finally, remember, you're going to want your patient to hold their abdomen as still as possible during some of these measurements, which means they will not be breathing during the course of your spectral Doppler recordings particularly. And you're only going to get a few good breaths from this patient population. So you want to use them wisely and coach the patients appropriately. If we were doing studies on beavers, this would not be a problem. You tell a beaver to take in a deep breath and hold it, they can hold it for up to 45 minutes, at which point your study would be completely over and done with. We, however, are dealing with humans, and in humans, after about 30 seconds, this is what they start to look like as they're starting to gasp for breath. And again, most patients will not even be able to hold their breath even a full minute if you ask them to really strain and struggle, which is what you don't want them to do. If you think about the process of taking in a deep breath and holding it, the tendency is to make our abdominal muscles rigid when we do that to help maintain that held breath, which is the last thing you want because you are taking your duplex ultrasound probe and you're pushing now on a rigid abdomen. You're pushing hard to get a good study. The patient is pushing hard back to maintain their breath hold, and you end up fighting one another and nobody wins in that process. So again, what you're really interested in is just breathing motion to stop. So coach the patient through a couple slow, deep breaths, and finally, at the end of a respiratory cycle, just ask the patient for a few seconds to stop breathing. This way, the respiratory motions in the abdominal cavity will cease. You'll be able to get your data. And if a patient just stops breathing rather than actively holding their breath, their abdominal muscles tend to be much more relaxed and you can position the probe much more easily. Nobody gets tired out with this technique. So they do not have to hold their breath very long, because what you have done is before you've given them this instruction, you have optimized all your controls. You have seen approximately where this vessel, for example, takes off from the aorta. You know where you're going to want to put your sample volume once the respiratory motion stops within the abdomen. So you have everything ready to go. You have your spectral Doppler display ready, your cursor is there, your sample volume is placed, and you're ready to go. So the instant they stop breathing, put your spectral Doppler sample volume in place, turn on your spectral Doppler display, get your recording, and in approximately 5 seconds you should have all the information you need, at which point you can tell the patient just go ahead and breathe normally while I check my image to make sure I got the information I need. You can do all your angle correction and other things on a frozen image. You do not need to do that on a live image. So the point is, be prepared to get data as soon as that patient stops breathing. Get your 5 seconds of data, and at which point then you're ready to let the patient breathe normally until you move on to the next site from which you want to record spectral Doppler or color Doppler information. It's very simple to keep doing that, and a patient can do this indefinitely with a little bit of coaching. Using these techniques, very simple abdominal preparation with a patient cooperation if they're compliant, and you get good breath holding or basically stop breathing cooperation from your patient, you're going to get a technically adequate duplex examination for chronic ischemia in more than 95% of patients the first time they come in. There will be that small fraction of patients who, for whatever reason, still have extensive bowel gas, which you just cannot penetrate. You're going to know this early on in the course of a study. You do not need to do any more than that. Just say, we'll try, send them home, we'll try it again at a later date. But that's an extremely small percentage of the patients you're going to evaluate for this problem. Let's look briefly at the anatomy of the mesenteric study and the vessels we're interested in. Primary interest are the celiac trunk, just below the diaphragm, and the superior mesenteric artery just below that. Of secondary importance is the inferior mesenteric artery, which comes off slightly anterior and lateral to the left, just above the aortic bifurcation. So that is a more minor player in the scheme of chronic mesenteric ischemia. Now, it would be nice if all aortas looked as good as this, but this is one of the very few textbook images I'll even show you where you see very clearly a celiac trunk and a superior mesenteric artery coming off in a very clearly visualized aorta with an obvious absence of any atherosclerotic disease. You are not going to see nice images like this in the vast majority of your patients, so don't hold out your hopes for that. This is much more typical, a good quality image of the proximal abdominal aorta just below the level of the diaphragm, the celiac trunk takeoff, the superior mesenteric artery taking off, and it typically does run somewhat then parallel to the aorta and anterior to the aorta. Color Doppler can be very helpful in finding and helping to identify these vessels. The celiac trunk and the superior mesenteric artery coming off the proximal abdominal aorta just below the level of the diaphragm. And again, they may come off at very strange angles, but color Doppler will help you identify even these tortuous origins of these two vessels. What you want to do is get your sample volume in place. You can angle correct after you have frozen the image, but get your spectral Doppler display, in this case of a celiac axis showing a good systolic rise time and somewhat sustained diastolic flow. The celiac trunk should be a relatively low resistance vessel. It's feeding the liver and the spleen, so you should have good diastolic runoff in a normal celiac waveform as shown here. You can actually do the celiac trunk Doppler from either a long axis or a cross-sectional view, whichever one gives you the best means for proper angle correction after you have frozen the image. This is a celiac trunk waveform taken from cross-sectional view. You can see the aorta down here, the origin of the celiac trunk. You get basically the same waveform, good systolic upstroke, good sustained diastolic flow. So whichever imaging orientation gives you the best view of the origin of the celiac trunk, it is perfectly okay to use that. The superior mesenteric artery you are almost always going to interrogate from a long axis approach as it comes off that proximal aorta. You can then also follow the celiac trunk out to the hepatic artery feeding the liver, and as I'll show you in a second, the splenic artery. Their waveforms in a normal situation, again, should be very similar to the celiac trunk. Good systolic upstroke, good sustained diastolic flow. And I show you this image because you see this is a real world image. There is a great deal of noise because Doppler gain is turned up very high. There may even be some venous interference, but it doesn't matter. You're interested in the arterial flow signal, and your ability to measure peak systolic and end diastolic velocities. And you can tune out mentally all of this noise and other aberrations and focus on the important parts of the waveform and the overall characteristics of the waveform itself. And again, an example of a splenic artery, again showing good systolic upstroke, good sustained diastolic flow. And the presence of this kind of noise and interference really is immaterial as long as you have a good waveform to work with on the arterial side. The superior mesenteric artery, on the other hand, if the patient truly is in a fasting state, tends to be a high resistance waveform where you see a very sharp systolic peak with a good systolic upstroke, but minimal end diastolic flow. If you have experience doing carotid duplex ultrasound, you can actually equate the celiac trunk to the internal carotid artery of the abdomen and the fasting superior mesenteric artery to the external carotid artery of the abdomen. The waveforms are surprisingly similar in those vessels. But in a fasting state, simply remember the superior mesenteric artery is a high resistance vessel. The gut has nothing to process, it is not demanding blood flow, and the small vessels in the gut are fairly constricted at that point. You can then follow, as I say, in long axis the superior mesenteric artery out parallel to and atop the abdominal aorta into the proximal segment, and again see that same type of waveform with a good systolic upstroke but very minimal end diastolic flow in this particular case throughout its course. Now, what are normal velocities that we should expect? This is a very simple table that give you approximate values. These are not absolute, but represent ranges. The normal proximal aortic velocity typically is somewhere between 60 and 100 centimeters per second with very minimal end diastolic flow. The celiac trunk, remember, is relatively low resistance. Typical peak systolic velocities, 80 to 120 or so peak systolic, approximately 30 to 40 centimeters per second end diastolic. The superior mesenteric artery in the fasting state is the high resistance vessel, typically 100 to 150 centimeters per second peak systolic and 10 to 20 centimeters per second only end diastolic. If the patient has had something to eat and the gut now is processing that food, you see about a 50% increase over normal in peak systolic velocity, up to maybe 150 to 200 centimeters per second. But the significant increase is the relaxation during the digestive process of the small vessels in the gut, and you should see at least a tripling of the end diastolic velocity over 45 centimeters per second if the patient in fact has had something to eat. And brings up another point. We used to do a caloric challenge with these patients and give them something to drink which had a known caloric content which would stimulate the gut, and we would then compare the fasting data to the postprandial data. And really that isn't necessary any longer to do given the quality of today's duplex ultrasound instrumentation. And in fact, this report published over 15 years ago now shows that very clearly the fasting study is extremely sensitive and specific for chronic mesenteric arterial disease, a very high negative predictive value of virtually 100%, and an overall accuracy greater than 95% in making this diagnosis. So it is no longer necessary to do this kind of postprandial challenge. All of the data you get in the fasting study is perfectly adequate to make the diagnosis of chronic mesenteric ischemia in these patients. So it's no longer necessary to do that. The criteria are very simple and straightforward. You're only interested in hemodynamically significant stenoses in the celiac and superior mesenteric artery particularly, and that corresponds to a greater than 70% diameter reduction. If the peak systolic velocity in the celiac trunk exceeds 200 centimeters per second, it exceeds that threshold, and you have good grounds for making the diagnosis of a significant stenosis in the celiac artery. So again, be it in cross-section or long axis, get a good shot at the origin of the celiac, get your sample volume in place, have the patient stop breathing, record your waveform, angle correct appropriately, and look at peak systolic velocity. And in this case, it clearly exceeds the threshold of 200 centimeters per second. You can safely make that diagnosis of proximal celiac artery stenosis. Just a technical point, note, because you're looking at high velocities in a deep structure, you're going to record high velocities, you're going to need to take your velocity scale or your pulse repetition frequency up fairly high. And in this case, you can see it's up to 10 kilohertz. What this may do is put extra sample volumes out there in your image. Just be careful that second sample volume is not in another blood vessel, as it will give you a confounding spectral waveform. But there is no harm whatsoever in having multiple sample volumes out there so long as only one is in the blood vessel of interest, even though you're using a very high pulse repetition frequency because you're trying to measure stenotic flows. One difficulty can be a total or near total celiac artery occlusion. You may not be able to visualize the origin of an occluded celiac artery clearly at all, and you certainly can't get Doppler signals from an occluded blood vessel, so you will not be able to record a proximal celiac artery flow, in which case the question is always, did I not see the celiac artery, or is it in fact completely or near totally occluded? What you need to do then is go to the common hepatic artery and look at flow direction. Pay particular attention to flow direction, because if the celiac trunk is occluded, the common collateral pathway is through gastroduodenal branches with reversed flow in the common hepatic artery, which is then providing flow into the splenic artery. And here we have a hepatic artery in the case of a celiac artery occlusion, and even though the waveform is displayed above the baseline, pay particular attention to the fact it is showing a negative Doppler shift, which is flow away from the probe, which is the opposite direction from normal. So this is in fact retrograde or reversed hepatic artery flow, indicating the diagnosis of a functional occlusion of the proximal celiac trunk. Diagnostic criteria for the superior mesenteric artery are equally simple. Again, a hemodynamically significant stenosis is greater than 70% diameter reduction. And here the predominant criteria is peak systolic velocity greater than 275 centimeters per second. Relatively easy to remember, 200 centimeters per second for the celiac trunk, 275 for the superior mesenteric artery. There are other data out there that also can offer secondary criteria. If the end diastolic velocity in chronic disease exceeds 55 centimeters per second, that likely corresponds to a greater than 70% stenosis. And if you do that postprandial challenge, because the gut is chronically ischemic, it is maximally dilated, and you are not going to see any significant change in end diastolic velocity comparing pre- and postprandial measurements. Again, these are secondary criteria. Very few labs still do a postprandial type of challenge. The primary diagnostic criterion remains that of peak systolic velocity for the superior mesenteric artery. And again, it's very straightforward, similar to the celiac trunk. Find the origin of the superior mesenteric artery, get your sample volume in place, record your waveforms, and look at peak systolic velocity, in this case over 400 centimeters per second, establishing that diagnosis of proximal SMA stenosis. You can also further help document that by going further out into the proximal superior mesenteric artery and documenting the presence of post-stenotic turbulence in this case, which you should see distal to any significant stenosis in the body. And here it does help confirm the presence of that proximal stenosis. The one anatomic anomaly I would like to point out, the most common one seen at this site, is a common trunk of the superior mesenteric artery and celiac. When you do see a common trunk, it's going to have a mixture of both superior mesenteric and celiac trunk velocities. So your peak systolic velocity may be somewhat elevated over the normally expected values of, say, 100 centimeters per second or so. But once you get out into the true celiac and the true superior mesenteric arteries, those waveforms will revert to the normal expected values, unless, of course, there is a stenosis present proximally. So again, that is the most commonly seen anatomic anomaly, is look for that common trunk, document flow, and then go further out and find where the true celiac takes off and the true superior mesenteric artery begins, and also document those sites as you would normally in a mesenteric Doppler study. So here you see the high resistance waveform, in this case coming off that common trunk further proximally, but again, sharp systolic upstroke, very minimal end diastolic flow in this case, a normal superior mesenteric artery origin. Management of chronic mesenteric arterial disease can either be by direct surgical reconstruction, or in this day and age we have the option of balloon angioplasty and stent placement. So in considering that, this is a CT evaluation of the mesentery showing the celiac and superior mesenteric artery stents very clearly. These can also be followed post-stenting very easily with duplex ultrasound, as the stents are metallic structures. They show up very nicely on ultrasound, and it's a very simple, straightforward study to do that follow-up. So very easily seen. In terms of patient survival, overall morbidity and mortality, etc., there really is no major difference between the open surgical repair and the endovascular or angioplasty and stenting type repair, no matter how long you follow these up. The big difference is the recurrence in symptoms and restenosis rate, and there is a large significant difference between the two in that the open surgical technique does have much more durability over the years. There is very often, in many cases, an early restenosis rate and an early recurrence of symptoms in the stented groups. This is a chart of freedom from restenosis. This shows freedom from recurrence of symptoms, and you can see even after just 2 years, less than 70% of patients are free of symptoms in the stented group. In the open surgical group, greater than 90% of these patients remain free of symptoms out to 5 to 10 years. So the durability of the surgical approach is much greater than that of the endovascular approach, and really the treatment needs to be individualized to the patient based on their age, relative medical comorbidities, heart disease, things of that nature. A very quick example, this is a patient in whom there was stenosis was seen at the origin of the celiac axis with a peak systolic velocity over 300 centimeters per second, and also again post-stenotic flow turbulence and very damp flow seen in the distal celiac. Likewise, in the superior mesenteric artery, you can see a peak systolic velocity of 369 centimeters per second, and you would see post-stenotic flow turbulence if you followed that vessel out as well. Post-stenting, 8 months later, the patient returned with recurrent symptoms, the reason being very simply they had recurrent stenosis in both stents. We now have peak systolic velocity in the celiac stent of over 270 centimeters per second, and peak systolic velocities over 400 centimeters per second in the SMA stent. So again, classic to form. The stent took care of the symptoms for a while. After 6 to 8 months, they recurred, and as evidenced with recurrent stenosis. So this is the common problem with stenting and angioplasty in these patients, is the recurrence. A few of the other things you might run across on the arterial side, one is median arcuate ligament syndrome. It's a compression syndrome in which the median arcuate ligament, right here sitting above the celiac trunk, extrinsically compresses the celiac artery, which can compromise flow in the celiac trunk. The way you differentiate this from a fixed atherosclerotic obstruction is just look at changes with respiration. When a patient has exhaled fully, the diaphragm has drawn up and the liver and spleen are pushed up in the abdomen, and this draws the celiac trunk up against the median arcuate ligament, and that will cause compression and stenotic-like flow in the celiac trunk. When the patient takes a deep breath in, the diaphragm drops down, it pushes the liver and the spleen down and further into the abdomen. It pulls the celiac artery away from the median arcuate ligament and will release that extrinsic compression, and you get relatively normal flow in the celiac trunk with a deep inspiration. So anytime you see a celiac artery stenosis or suspect a stenosis, take spectral Doppler measurements when the patient has taken a full breath in and is holding it, and when they have fully exhaled and are holding it, looking for significant changes in peak systolic velocity. And again, here is a patient, we're at the origin of the celiac trunk, and you can see just in a normal recording of a waveform some respiratory variation in that peak systolic velocity. So we would then go with a suspicion of possible median arcuate ligament compression. We would go to the extremes of the respiratory cycle and repeat our spectral Doppler measurements. With the patient lying down, the patient has taken a full breath in, we still see somewhat stenotic flow, peak systolic velocity over 200 centimeters per second, even with release of some of that compression. When the patient then exhales completely and the liver and spleen are pushed farther up in the abdomen as the diaphragm raises, we see the celiac is also pulled upward. You can see how it has changed its course from this inspiration to exhaling, change its course, the crimping that goes on right here, and in fact here it is so severe we have almost lost all celiac flow. We see not a stenotic peak systolic flow, but we see nearly absent flow because there's a near complete occlusion of the origin of the celiac trunk in this case. The other maneuver to perform in these patients when you suspect median arcuate ligament syndrome is test them not only supine, but have them sit up. In this case, we just saw also a large gastric artery was seen with retrograde flow filling the hepatic artery, so there was evidence of chronicity indicated by collateral filling of the hepatic artery. And again, the flow direction in that gastric artery indicating retrograde flow and collateral filling. But the second maneuver, as I mentioned, is sit the patient upright and repeat the celiac trunk measurements. Now the patient is sitting upright. We have them take a deep breath in and hold it, and we have normal flow velocities of 164 centimeters per second in the celiac trunk. You have them let the breath out completely and hold it. Again, revert to stenotic flow. So here we see large significant changes in celiac artery flow based on the respiratory cycle and based on whether the patient is supine or upright. In the upright position, gravity will help pull the liver and the spleen down away from the diaphragm further into the abdomen. It will help pull that celiac trunk further away from the median arcuate ligament and relieve some of that compression syndrome. So anytime you suspect that, have the patient tested supine, sit them upright, and look at the extreme ends of the respiratory cycle, inspiratory and exhaling. Another anomaly you might run across if you follow the splenic artery out is a splenic artery aneurysm. Typically, these are fairly benign lesions. They can cause significant morbidity if they do rupture, just like an aortic aneurysm. But most of these tend to be small and are followed clinically. I only bring this up because there is one important patient group in whom you might consider elective treatment and resection, and that is the relatively young female who plans on having children or who does not have any children and does plan on having some down the road. The problem being because of the hyperdynamic state during pregnancy, particularly the second and third trimesters, if a splenic artery aneurysm should rupture at that point, there is over 90% mortality reported in many series for both mother and fetus in that case. So it is a dangerous condition, similar to a large aortic aneurysm in that case, in that particular patient population of the relatively young women who are planning on having children. Otherwise, these tend to be followed. The recommendation now, if they get above 2 to 2.5 centimeters in diameter, they can be fixed electively at any point. Or if they start causing symptoms, they can be fixed electively. On the venous side, a number of things one will be interested in looking at depending on the patient's clinical presentation: the portal hepatic system, the mesenteric venous system itself, and the inferior vena cava. If you look at portal venous hemodynamics, normally flow should be into the liver. The portal vein accounts for about 2/3 of hepatic blood flow, but because it is draining the gut, it only provides 50% of the hepatic oxygen supply, the remainder coming from the hepatic artery. And it is formed, the portal vein formed at the confluence of the splenic and superior mesenteric veins, which run along the superior mesenteric artery and the splenic artery. Normal superior mesenteric vein is easy to find. Look for the superior mesenteric artery, and it is the large vein adjacent to that. The splenic vein, the same thing, a large venous structure adjacent to the splenic artery, and both have typical low velocity, fairly steady venous flows. They combine to form the portal vein, which normally should be provide a little steadier flow than this. This is a very pulsatile portal venous flow in a patient who probably is reflective of tricuspid insufficiency or significant elevated right heart pressures, which are being transmitted through the liver. And again, this shows the other phase of that, where you actually have flow going out of the liver in this case, And again, if you look at the to and fro flow in that patient with tricuspid insufficiency, you're going to see a flashing of red and blue color in the portal vein, which will correspond to the flow out of the portal vein and into the liver as you get that to and fro flow phenomenon in a patient with excessive elevated right heart pressure, in this case secondary to tricuspid insufficiency. But more normally, the portal vein is going to have some respiratory variations and will be steadier flow into the liver. You may have extrinsic compression of the portal vein if you see significant ascites. Patients with portal hypertension do tend to have ascites many times. And if you get enough of this in the abdomen, it will extrinsically compress the vein and will cause diminished flow in the portal venous system. Once you get through the liver onto the hepatic side, in the hepatic veins, you're going to see much more pulsatility at the heart rate, particularly since now you're emptying into the vena cava at a spot very close to the right heart. So you're going to see all of that heart rate pulsatility transmitted back into the portal veins routinely, which you do not see on the hepatic veins, which you do not see in the portal venous system. So expect to see this kind of a pulsatile venous flow signal in the hepatic veins. In a patient with portal hypertension, regardless of the cause, you will also see the so-called hepatofugal flow or reversed flow in the portal vein, with flow going out of the liver it's coming through collateral pathways, but the portal vein is now looking for a way to empty because it can no longer empty through the normal channels in the liver. It is going to find collateral pathways. It's going to open up the azygous vein, the coronary vein, the splenic vein, the superior mesenteric vein, any system it can find, and it's going to put that system under chronic elevated pressures, which may lead to significant varicosities. And oftentimes you'll see something like associated splenomegaly, where you have a very large enlarged spleen simply because of the venous hypertension that's now been created by the portal venous hypertension that is ongoing. So again, you see this 18 centimeter spleen. Typically the spleen should be in the neighborhood of 10 to 13 centimeters in length or so. You see a very enlarged spleen, and you may see very complex dilated splenic vein varicosities, particularly at the hilum of the spleen, which may have associated gastric varicosities, a very complex venous network in the abdomen associated because of the portal venous hypertension. Most commonly now, this can be treated with the so-called TIPS procedure, or transjugular intrahepatic portosystemic shunt, in which a catheter is placed down the inferior vena cava into the hepatic veins, and direct communication with the portal vein is established, and a stent is placed in that system to shunt flow from the portal vein into the hepatic veins. Again, the nice feature of these stents and shunts are they tend to be metallic, and they show up very clearly by duplex ultrasound. Here's the portal vein, here's the stent, again emptying into one of the hepatic veins. You can see it very clearly. You can document the hemodynamic flow patterns in these stents as well using color Doppler and spectral Doppler. You can look at the direction of flow in the portal vein to make sure that it is emptying properly. And again, using your spectral Doppler, document that there is restoration of basically normal portal venous flow in a patient with a functioning TIPS procedure. You look inside the stent itself, you may see somewhat elevated velocities. If there is a stenosis within the stent, which is the most common cause of failure of these procedures, there will be a stenotic intimal hyperplasia develop within the stent, which will lead to closure or the absence of adequate emptying of the portal vein. You will see, again, the patient will revert to hepatofugal or retrograde flow in the portal vein. You will see evidence of stenotic flow within the stent and post-stenotic turbulence downstream from that, even on the venous side. In this case, the stent is wide open. It has basically normal flow hemodynamics, slightly elevated velocities, but they are consistent throughout the stent. There's no focal elevation in velocity, which would be indicative of an in-stent stenosis of any kind. And then looking at the emptying of the hepatic veins normal into the inferior vena cava in a case like this. The heart rate pulsatility, which is a normal finding in the hepatic venous side, and again the stent emptying into the right hepatic vein directly at the inferior vena cava. See the normal arterial, heart rate pulsatility that you get on the hepatic side. You can use power Doppler if you suspect stenosis. It's a very good way to show the residual lumen versus the stent in this case, and you can see that stenotic region within the stent very clearly with power Doppler. You can even get into three-dimensional reconstruction in today's duplex ultrasound systems, which show that whole system very clearly, the stent, the stenosis, and the inferior vena cava. Portal vein thrombosis can be another complication which will lead to portal hypertension, in which case it's like thrombosis in any other vein. Expect to see an echogenic filling of the lumen and the absence of any flow in this particular case. Again, another example of portal vein thrombosis, associated ascites, and chronic changes within the liver itself. You may have cavernous transformation, some recanalization of the thrombus, some collateral flow providing flow into the liver, but again, the main portal vein remains essentially thrombosed and non-functional at this point. And it's just a matter of making that identification and documenting that specific finding. Mesenteric venous thrombosis is a relatively straightforward diagnosis with duplex ultrasound. Clinically, it's much more complex because the patient now typically presents with vague abdominal complaints of pain. They're very non-specific findings on physical examination in the abdomen, and typically it may be more than 2 weeks from the onset of these symptoms to reaching the diagnosis of mesenteric venous thrombosis, either involving the splenic vein or the superior mesenteric vein. Once the patient is sent for a mesenteric venous examination, however, the documentation of this diagnosis is very straightforward. Here, identifying the distal splenic vein, ability to see that it is completely thrombosed with an absence of flow, superior mesenteric artery down here, you would find the superior mesenteric vein and document whether it is patent or not as well. Document portal venous flow, and you've in a matter of a few moments established the diagnosis. One thing that is being done at more and more centers also in this realm involving the inferior vena cava is actually using ultrasound guidance instead of fluoroscopy to place inferior vena cava filters to prevent pulmonary emboli from existing lower extremity deep vein thrombosis. And again, using the ultrasound guidance, it is very easy to place these catheters, make sure the stent's in the right position, and deploy the stent completely under ultrasound guidance without the need for any radiation or fluoroscopy in these patients. One final syndrome I want to mention before closing is the so-called Nutcracker syndrome. If you think about the anatomy of the aorta and the superior mesenteric artery, remember that the left renal vein runs right between those two vessels. So if those two large, thick-walled, high-pressure arterial structures anatomically come too close together, you are capable of extrinsically compressing and closing off the left renal vein, similar to what the jaws of a nutcracker closing. So again, what that will look like with duplex ultrasound is you will see the left renal vein right here extrinsically compressed as it is trapped between the superior mesenteric artery and the aorta. The extrinsic compression there in this case chronically has led actually to complete thrombosis of the mid-segment of the left renal vein. The inflow to the kidney has remained the same. The outflow has got to go somewhere, and collaterals will readily develop. There is a small collateral branch even seen here going up to the splenic vein and superior mesenteric vein. There's also anatomically the ovarian vein present in these patients, and that is the classic collateral source of emptying for the left kidney when there's a symptomatic Nutcracker syndrome. In fact, the most common presenting symptom of the Nutcracker syndrome is a pelvic congestion syndrome, because the ovarian vein tends to become very large and dilated, and now there's retrograde flow down the vein into the pelvic region on the left side. This is the common iliac artery and the common iliac vein, and you can see the ovarian vein flow direction is the same as the common iliac artery, which is reversed from normal, creating increased venous flow into the left pelvic region, and particularly during specific phases of the menstrual cycle in young women can cause severe pelvic congestion and pelvic pain. And just remember, it is basically the problem is referred by excess venous flow through the ovarian vein as a collateral pathway emptying from the left renal vein being obstructed And again, you can document all that fairly readily by paying attention to the anatomy and looking at flow direction in these particular structures. Thank you very much for your attention.